Well, welcome everyone, and thank you for joining our webinar today with Christina Young and Philip Cross, authors of the new 9th edition of Phillips & Young's Healthcare USA. Christina and Philip will be talking to us today about MACRA, which is the Medicare Access and CHIP Reauthorization Act, which was passed in 2015, and they're going to be talking to us a little bit about how it compares to ACA, how it complements it. My name is Sophie Teague, and I'm the Senior Marketing Manager for Public Health and Health Administration here at Jones & Bartlett Learning. And for those of you who are not familiar with Jones & Bartlett, we are a provider of instructional, assessment, and learning performance resources for the secondary, post-secondary, and professional markets, and we specialize in the areas of health and safety. So at this point, I would like to introduce you to our two presenters, Christina Young and Philip Cross. Christina Young is a clinical assistant professor emerita who also served as the co-director of the Health Services Administration concentration in the Department of Epidemiology and Environmental Health at the SUNY Buffalo School of Public Health and Health Professions. For more than 20 years at the University of Buffalo, she taught graduate courses in healthcare organization and health policy for students in the fields of public health, law, and management. For several years, she also taught graduate courses on healthcare systems at Canisius College in Buffalo. Ms. Young is also president and owner of Christina M. Young Associates, which is a management consulting and training firm specializing in health and human services organizations. Her career has included administration of maternal and child health programs for a county health department. She was also the executive director of a multi-county public health alliance, and the executive vice president of an organization dedicated to advancing the joint interests of a major teaching hospital and a health maintenance organization. She has her bachelor's degree in biology from Canisius College and her Master of Science degree in epidemiology from SUNY Buffalo School of Medicine. Philip Cross is an associate professor in the University of New Mexico School of Medicine. He is also the director of the Biomedical Informatics Research Training and Scholarship Unit at the UNM Health Sciences Library and Informatics Center. He's also the section chief of clinical informatics in the UNM Department of Internal Medicine. Before joining UNM in 2004, Dr. Cross received his Bachelor of Science in Computer Engineering from the Rochester Institute of Technology and his medical degree from the Medical College of Ohio. He completed a research fellowship in biomedical informatics at the Indiana University Medical Center, where he also earned a Master of Science in Clinical Research. And at UNM, in addition to practicing as a general internist, he directs a postdoctoral research fellowship in biomedical informatics and a new clinical informatics fellowship for physicians. So with that, I'm going to now hand things over to Christina Young.
Good afternoon, everybody, and thank you for joining us. I'd like to open our session with a question for a quick poll. And that question is the relationship between the Affordable Care Act, the ACA, and MACRA clear to everyone?
And you can answer that question by clicking the feedback button, which is on the right-hand side of your screen. It's a small icon that looks like a talking bubble with a check mark in it. If you simply click that, you'll see a yes or no option, and if you could select yes or no, we can see those results. And we're getting quite a few no's, actually. We've got so far 10 no's, 15 no's, and 2 yeses, 18 no's. So the no's are going up. So Christina, definitely some need for understanding on the differences between MACRA and the ACA.
Okay. All right. Well, as you see on your first slide, that MACRA passed in 2015 and the ACA passed in 2010 are separate but complementary laws. The ACA attempted, after many, many decades, to begin to approach universal coverage for all Americans. And it had several major features. One was to promote value over volume-based care, expanding coverage and controlling costs through the establishment of health insurance marketplaces, where individuals could purchase health insurance coverage through state or federal resources, expanding Medicaid, defining the baseline of quality insurance. And many of you probably have heard recently about the controversy in Congress over the 10 essential health benefits. And essentially, what that 10 essential health benefits provision of the ACA did was ensure that all health insurance policies purchased by Americans would cover 10 basic services. For example, in the past, insurance policies may not have covered maternity care. They may not have covered preventive care. They may not have covered services for mental health services or care for mental health services. Individuals had to buy a basic policy and then pay extra to add on those riders. So the essential health benefits provision ensured that quality was uniform across all basic types of health insurance. The ACA also intended to promote a population health and prevention approach using public health principles and incentivize care coordination among all providers, physicians, and the individuals who support them. The MACRA, which was passed in 2015, also intended to promote value over volume-based care by using revised payment systems, incentive systems for physicians and other care providers, and also alternative payment models, or APMs. Those alternative payment models include things such as patient-centered medical homes, accountable care organizations as two examples. It also intended to standardize quality reporting metrics. Those are the measurements that come from physicians providing care to Medicare patients. It reauthorized the Children's Health Insurance Program through the end of this fiscal period, 2017, so it reauthorized it for 2 years. And it shifted Medicare fee-for-service payment to alternative incentive models by 2018. So they are clearly complementary in that they're promoting quality, promoting value over volume-based care, and incentivizing providers to provide high-quality care. But they are different laws, however heavily related, as hopefully my explanation has indicated. The ACA, as many of you I'm sure will recall, was a very difficult piece of legislation to get through. Nonetheless, Mr. Obama and his administration were able to do that in approximately 14 months from him taking office in January of 2009. Support was for the individual mandate, which again has been a highly controversial element of this, of the law. But the individual mandate was intended to ensure that every American purchased health insurance coverage or would be required to pay a nominal penalty. The purpose of that was to ensure that young and healthy people would buy insurance in order to balance the pool of risk among the much more costlier, older, and sicker individuals. We had more than 46 million un- or underinsured people in the country, which internationally, on comparison, is unprecedented for a developed country such as the United States, and that has been true for many years, decades. It also intended to improve the Medicare drug coverage, which was a popular feature of it because so many individuals in the U.S., 50-plus million individuals in the U.S. had what was called the donut hole in their Medicare prescription drug coverage, which essentially dropped them off a cliff after a certain level of spending in terms of reimbursement. Expanding Medicaid by lowering eligibility requirements to enable more individuals to take advantage of the Medicaid program in their states, and it also covered preventive care at 100%. So there was very significant support based on those 5 parameters. Opposition came from individuals who didn't believe that Americans should be forced to purchase health insurance or pay a penalty. Individuals in Congress who believe that government should have less of a role rather than a greater role in providing health care opposed the law. It was opposed as being too costly, that it had the potential to increase the federal deficit. It did not include provisions for malpractice insurance reform, and there was widespread discussion about concerns regarding employers being required to offer health insurance would lead to job losses. So there were substantial elements of support and opposition both to the law, and as we know, it passed by a very slim margin. in Congress with virtually no Republican votes. So I think Dr. Croft, as a practicing physician, is going to address the MACRA bipartisan support elements.
Hello, everybody. My name is Phil Croft, and I want to thank Sophie for that very kind and generous introduction. Continuing on here, MACRA, and this is one of the key things about MACRA, is that it received broad bipartisan support. Essentially, the Republicans like they're sort of what you might hear of the triple aim, and the idea is to increase patient satisfaction and quality, number one. Number two, focus on population health, and number three, manage costs. So in a sense, the Republicans sort of resonated with the managing costs a little more in their traditional sort of platform and approach, and the Democrats sort of resonated with the patient satisfaction, quality, and population health approach. So it was kind of like the slogan was, there's something for everybody in this bill, and it was much less controversial. And because it has had broad bipartisan support, there has been very little talk about it in the media and criticism, as both the Democrats and the Republicans have signaled, and even the new President's administration has signaled, that they do not intend to repeal or replace or change MACRA up to today, as far as I can tell. But essentially what MACRA does is it is based on the same set of sort of core values or basic elements of the ACA, which the idea is, rather than having the federal government through Medicare or states for Medicaid pay for volume. In other words, traditionally, if you're a physician and you see more patients, you get paid a fixed cost for that patient based on the disease they have and what you're doing, if you're doing procedures and whatnot. And if you see more patients, you get paid more. And that's all fine and good, except they found out that people tend to do as much as they can to make more money. And so what they really want to pay for is better quality, and make sure that if you're going to do more, that you're actually providing better quality. So the idea is to incentivize physicians to do that. They withhold a portion of the payment that you receive for seeing a patient, and then they will sort of measure the quality of your care, and then then in the future they sort of quote unquote pay that back by either increasing the amount you receive for that service or decreasing it based on how well your quality is working. The idea is to standardize. The other thing that happened too is there were several government initiatives that had different quality measures. As an example, for patients with diabetes, they would measure hemoglobin A1C, which is a lab test that sort of measures your average blood sugar over time. And this would have to be reported. So if I saw 1,000 patients with diabetes, they would want to know what my average hemoglobin A1C level was amongst those 1,000 patients, because that would be an indicator of how well I'm controlling their blood sugar and therefore quality. The problem was that many standards were set. There were many different quality programs. There was something called Meaningful Use, which was focusing on the use of health information technology. There's something called PQRS, or the Patient Quality Reporting System, and they all have different sort of reporting standards. As an example, in one government program, you just reported if the patient is smoking, yes or no. In the other government program, you'd report if the patient is smoking, but if they said no, did they quit recently, within 6 months? Have they never smoked? There were many different answers. So it was becoming very confusing to meet the requirements of various quality standards when you had different things you had to report for the same item, like smoking. So what MACRA did is it standardized the reporting of many of these quality metrics or measures to make it less complicated. And as I mentioned, the Meaningful Use program was a government incentive program that paid physicians and healthcare organizations about $20 billion. This came, if you remember, early in the Obama administration in the quote-unquote stimulus package when they were trying to boost the economy. One of the things they did to incentivize the adoption of electronic health records and other health information technology was to pay physicians and hospitals and other healthcare organizations that did adopt this technology and then met such certain meaningful use metrics. In other words, that you were using it to have a patient portal, for example, or you were writing e-prescriptions at a certain rate, things like that. Well, that program had 3 phases, phase 1, phase 2, phase 3. Most hospitals and physicians were able to meet phase 1, not all. Phase 2, there were problems with, and the complexity of the metrics that physicians and institutions were supposed to meet were very complicated. They had changed several times as the program went on, and consequently, there was a large number of hospitals and physicians that didn't meaningfully use stage 2. So what they did, they were planning to do a stage 3, which was even more complicated and required more comprehensive use of these technologies, and that never really got off the ground, and so they're subsuming that into the MACRA legislation. Interestingly, if you note on the list there, it says advancing care information. The meaningful use name has I was at a conference 2 weekends ago, and there was a representative from CMS there, and she actually said, we thought that there was so much negative connotation with the word meaningful use because so many people were struggling to meet stage 2 that in MACRA, they changed this a few months ago to advancing care information, and so that it would have less of a negative connotation. But that's just a point that the jargon around this and the complexity is significant, and it seems to be ever-changing. And ever-changing in unpredictable ways. Like, I was really caught by surprise, and I'm somebody who wrote the book, and I spent a lot of time keeping up on this stuff, and I had missed that they had changed the name of this section of MACRA. Essentially, what MACRA does for physicians is that there's 2 options. As Christina mentions, there's the alternate payment methods. That's sort of where they're running a number of experiments, or you can have where you have large groups of patients, and your large medical group or hospital or large healthcare organization will say, basically, we'll just take a bundled payment, and we'll to treat X dollars, we'll take X dollars a year to treat patients with diabetes, and whether that patient comes in no times, 1 time, or 100 times, they have to take care of them. And they're running a number of trials in various places around the country with various HMOs. And these are also called accountable care organizations, and they have to demonstrate certain quality metrics as well. And but what most physicians are going to opt to do is called MIPS, which is a program for individual physicians and health systems. Okay. And oh, we're still on fire. I'm getting a little ahead of myself here. But essentially, the MIPS program is a program where you have to identify from a list a number of quality metrics that you track and report to the government over time. There's a formula that's involved, and then based on how well you do with those quality metrics, your future payments will you'll either receive a bonus of a few percent, or you'll get penalized a few percent based on how well you met those quality metrics. Other things I should probably mention is that there's something called the doc fix that MACRA also did. It essentially, Medicare had not put in a permanent sort of rate formula for as the cost of healthcare went up each year, rather than having sort of a scale where it would increase on some kind of predictable basis. They would each year would just add, just kind of fix it for 1 year and say, okay, well, this year we're increasing reimbursement for physicians by 1 year. And then the next year they'd have to vote on it again because the actual price people would receive would revert back to that previous price. And this went on for many years, to the point where about a third, I think, of the reimbursement was actually through the quote-unquote doc fix, which was very disheartening for physicians that were trying to plan and make financial plans and whatnot, and they were worried that at any time the doc fix might go away, and then they would note a rather dramatic reduction in the amount of fees they would collect. During the negotiation for MACRA, the Republicans conceded a $200 billion cost offset with Medicare, with provider spending reductions and cost increases for high-earning Medicare recipients. And the Democrats sort of said, well, if you give us that, then we will just allow the Children's Health Insurance Program to be reauthorized for 2 years instead of 4. So there was a lot of give and take. But basically, Democrats and Republicans like this because the bill had something that they both, as I mentioned before, resonated with them. So as I mentioned before, the doc fix became permanent. So there's a predictable physician Medicare reimbursement level now. You don't have to wait for Congress to pass a bill every year. They fixed a number of things. As I mentioned before, MIPS, you get a composite score. So as you pick your quality metrics, there's a formula where it says advancing care information, forming with meaningful use, works out to 25%. And there's a number of quality things you have to do, like so many of your patients have to sign up and use a patient portal where they can view their own lab tests, et cetera, is one example. Other examples are the percentage of electronic prescriptions that you use, et cetera. And then that all feeds into your advancing care information score. And then there's also clinical practice improvement activities that you can do, sort of process improvement, resource use, like how often, if you're a primary care doctor, how often do you refer people to subspecialists for a given illness and severity, things like that. And then there's quality as far as outcomes. In other words, how well are the diabetics that you're treating, how well is their blood sugar doing over time on average, et cetera. And the interesting thing is the adjustments are 2 years in arrears. So if I do very poorly this year, the penalty will go into effect 2 years later, and vice versa. If I do very well this year, it takes them a whole year to collect the data, a whole year to sort of analyze the data, because there's a fixed pool of money, and they analyze the data and they look at how much money they have and they say, okay, well, they kind of grade on a curve, and then so many people will get the incentive and so many people will get the penalty. They only have so much money to do that, and they will allocate that based on how well everybody did. And then the nice thing about APMs is you don't have to participate in the MIPS program. So if you're an individual physician, it's a little less onerous, potentially, because your organization is sort of running the quality improvement program for you. But you're still going to have to change the way you practice to help the APM do all the reporting they need to do and whatnot. And then you're going to have to meet all the financial targets as well. This basically provides a lump sum payment based on 5% of the previous year's estimated aggregate expenditures according to a fee schedule. So in other words, they give you a bonus if you set up one of these organizations and are successful with it. And for individual physicians, I already mentioned this, it arguably could be a little bit easier because your institution is sort of structuring its practice model like an accountable care organization, where you're sort of taking on care based on populations and saying we'll care for population X, and we'll take a flat rate for each patient in there, whether they come to see us once or 20 times a year. Okay, Christina, I'm hitting the ball back to you.
Okay. In preface to this slide, I'd just like to make a few clarifications, and I'm hoping that the 80-plus individuals who are listening to us will be the mouthpieces for allaying the confusion that seems to exist at all levels of American society at this point regarding what is really going on with the repeal, replace, repair rhetoric that's been flying through the air for many months now in the media. First, it's important to realize that President Trump, on almost, I think it was his first day or second day in office, signed an executive order, which some of you may have read and reviewed. It's an executive order is a very vague directive, in this case, to make changes in very broad terms that will benefit Americans. And I'm chuckling as I say that because it's extremely broad terms. There are no specifics in it as to how, for example, the Department of Health and Human Services would go about implementing the changes in order to affect that broad, generally positive result. Irrespective of the budget reconciliation that was taken from voting status, was not voted on last week, the executive order stands. What is going to happen with that executive order going down the road, no one knows. There are so many political factors wafting through the environment that it's becoming choking to try to figure out what the future direction with this may be. But as a point of clarification, what happened last week with the deliberations around the budget reconciliation bill does nothing to change the fact that the executive order is still in place. Finally, one important other distinction. That legislation, the budget reconciliation bill that did not reach voting status in Congress last week, was pulled from vote, is not the repeal of the Affordable Care Act. The Affordable Care Act is a law, and repealing a law is an entirely different matter from a budget reconciliation act or bill. The budget reconciliation bill could have very significant effects on the law because it can essentially gut provisions of the law that have to do only with the areas of taxes and revenues, but it cannot repeal the law. That's an entirely separate process. So with those points of clarification, the executive order, which again is limited to federal budget, taxes, and revenues, could or may eliminate the individual mandate and the penalty, which as it was written into the law originally was deemed a tax. That was, some of you may recall, a subject of Supreme Court deliberation initially. The employer mandate to provide health insurance and employer's tax penalty, premium tax credits and cost-sharing subsidies in the health insurance marketplaces. That is, federal subsidies that enable people to afford health insurance premiums by providing them either tax credits or direct dollar subsidies. It could eliminate the Medicaid eligibility expansion provisions. To date, 31 states in the District of Columbia have expanded Medicaid, and this particular executive order could eliminate that eligibility expansion. It could eliminate the Prevention and Public Health Fund, which we know was the first ever stream of funding for public health activities that was guaranteed in the federal budget. There's been significant erosion of that Prevention and Public Health Fund already. That's a subject for another discussion. But it could eliminate the Prevention and Public Health Fund from the ACA, and it also could eliminate revenues, federal revenues, from provisions that were built into the law to help pay for its various costs. And those included what was dubbed a tax on health insurers' fees and taxes on the sale of medical devices and certain pharmaceuticals. So the executive order, if it were to be carried out, could in fact eliminate these provisions of the law, but it does not repeal the law. Okay. So
Christina?
Yes.
I just want to make one comment that
sure.
When a law is passed, the other thing is that the executive order only allows the president to adjust the regulations. So when a new law is passed, like the ACA, right, it sort of has the broad brushstrokes. It has the funding. It takes quite a long time, and that's why it took several years for the ACA to kind of start up, because then they give the law to Health and Human Services and Medicaid and Medicare, and they need time to actually write the regulations. In other words,
they have to write the rules and regulations.
They have to write the rules of how do things actually work on the ground, and this takes a long time.
Yes.
What an executive order does is it allows the president to direct specific sort of regulations to take effect, but it's still supposed to be as interpreted by that law. So what an executive order does is it says, well, what I'm telling you to do, Health and Human Services, I'm telling you to interpret this legislation in this way. And then the
in
sort
very
of
broad brushstroke.
Right, in very broad brushstrokes.
Yeah.
And you've got to change all the mechanisms of how all this works on the ground to work in the way that I say. Now, what's going to happen, though, is like already several states, like I think Ohio and whatnot, have signaled, well, we like Medicare expansion. It's helping our people get insurance. Even states with Republican governors like that. So what they're going to do is they're going to sue the federal government and say, I think that the president is directing the regulation change is no longer congruent with the spirit of the law, and
right.
then it will go into the courts. So
that's the proverbial intent of the law. It's inconsistent with the intent of the law. Yep.
And so this is why, even though he passed the executive order, nothing has really changed, because the agencies have to have time to sort of digest this and then make changes to the law and then publish the changes to the regulations, publish them, and then you're going to see a series of legal actions. And what they're going to try to do is get a temporary restraining order on the legal actions to stop them so that they can continue receiving funds through Medicare expansion, et cetera.
And for example, Phil, this is exactly the kind of thing we're seeing going on with the President's executive orders, the two of them, around immigration.
Exactly.
They've been enjoined by the courts.
Right.
And so nothing is, nothing is
right.
moving forward. So,
right.
and let's bring up the next slide and we'll talk for a minute about the rulemaking process. Okay. So here, just on a point of clarification, we'll go back to the rulemaking process in a second. The ACA components requiring legislation to change, these are only examples. So an executive order can't change these things. The law actually has to be changed, and it requires legislation. So that's a separate process. That includes such features as the family coverage for kids up to 26. And this is one of the reasons that's that 26 up to 26 years of age is a good example. This is one of the reasons why the public is so confused, because while the politicians are talking about the budget reconciliation bill, they're throwing in all this stuff. Well, don't worry, the kids over 26 will be able to stay on, and we won't take away lifetime limits for covered benefits, and we won't. Those issues cannot be dealt with in the budget reconciliation process for the most part. They actually are going to require changes in the law. So this gets very confusing for people.
And the reason they're doing a budget reconciliation as opposed to a new law is because a new law is filibusterable, if that's a word, in the Senate.
It probably is now.
Right. So in other words, the Democrats could filibuster the bill, and they would need 60% to pass the law. A budget reconciliation cannot be filibustered, and they only need a simple majority. So that's why they chose to use the budget reconciliation, because they assumed the Democrats would filibuster, and then they would have to kind of come to the table and make a deal.
Right.
So that's why they're doing this very strange thing with the Reconciliation Act.
The other thing to point out on the Reconciliation Act is that, and this is not a well-known fact, the parliamentarian for Congress and the Senate parliamentarian determines, based on past precedent, whether or not a bill, such as the one that was tabled last week, actually conforms to those rigid requirements for a reconciliation. That is, that it has direct effect on either revenues or taxes, and it can't exceed those limits legally. So even if that bill were to have gone forward, there still may have been changes to it by the parliamentarian relative to whether or not it actually conforms with a reconciliation process. So that's another wrinkle in the whole situation. It's interesting that the political rhetoric makes this sound very simple and straightforward. This is not the way our democracy works, and for good reason. I think we're all learning. So our presidential candidate, constantly saying day one we're repealing the law was not only naive, it was ridiculous, because that's not how the system works. It's very complex, and for good reason. All right, so things like changing the baseline quality of insurance, that is like throwing out the essential benefits requirement, reinstating dollar limits for covered benefits. In the old model, a person's insurance policy could actually be, if they had a severe illness or repeated hospitalizations, for example, could actually exceed a lifetime limit that was built to their insurance policy, and when they were the sickest and most in need, would find their insurance expired. And reinstating co-pays for preventive services, which was another feature of the Affordable Care Act, in that it encouraged people to use preventive services by not requiring co-pays.
So
okay.
if you have recently visited your primary care doctor for an annual physical, you will note that you don't have to pay a co-pay for that. If you visit your primary care doctor because you have a cold, upper respiratory infection, or specific problem, you will pay the copay. That waiving of the copay for the physical is considered a preventative service, and so that's why you don't have to pay the copay.
Okay, so the repeal, replace, repair rhetoric continues, and without changes in the law, by 2018, the Congressional Budget Office they actually have done 3 reports, including this one in January, estimating the costs of making changes to the Accountable Care Act. And for anyone who's interested, I would definitely suggest that you go to the Congressional Budget Office website, which is just www.cbo.gov, publications. The most recent one of their publications was issued on March 23rd in response to a request from Speaker Paul Ryan concerning the impact of the revised legislation they were trying to get up for a vote. But in any case, by 2018, the CBO suggested that without changes in the law, if the executive order were implemented affecting revenues and taxes, it would destabilize insurance markets by changing, as we mentioned earlier, the risk profile of people in the markets from mixed and balanced profile to a much higher risk one. An estimated drop of 10 million people from the non-employer, and that's also referred to as the non-group market, health insurance market. Drop about 5 million newly Medicaid insured, drop about 3 million from employment-based coverage, and initially increase non-employer-based premiums. Again, these are people who are not in the employer groups, about 20 to 25%, with almost a 50% increase after the subsidies were eliminated. Very important, as Phil just mentioned, that implementing changes requires significant time. There are requirements for notice and comment rulemaking. The changes to rules or regulations have to be made public, and this is the point where the enjoining forces, the people or the organizations typically who oppose the changes, will jump in with their legal actions or their lawsuits.
So as an example, I would just tell, like when HIPAA, the Health Insurance Portability and Accountability Act for privacy came, when they passed the law, it took many months for them to start writing the regulations. Then they had to have a public comment period. They got over 50,000 comments. Then they have to process the 50,000 comments and address them all. And you can actually go online and they will summarize what all the comments they received are. All the comments received, you can actually, is a matter of public record, and you can actually go and see how they commented. So this is a very, this happens with every major law that changes regulations that are existing, the public comment period. And of course, this is such a controversial thing and it's got so much attention, they're probably going to get even more than 50,000 comments that they're going to have to process and address before actually implementing the regulations.
Yeah, and extremely controversial. And of course, as people now are, some people in Washington are talking about crossing the aisle to try to gain some bipartisan traction to make some needed and important changes to the Affordable Care Act. And we've repeated many times, no one ever said it was perfect. We've gained full 6 years of experience with it. There are things that should change and that would be beneficial to change, but the expectation of getting bipartisan traction getting bipartisan traction is extremely difficult. One can think of an example where there could be bipartisan support for the ACA's maintenance of taxes on health insurance premiums. These are the organizations that were taxed, such as health insurance companies, medical device manufacturers. Those taxes represented the fact that those industries, health insurance and medical devices, two examples, would be gaining millions of potential new customers as a result of the Affordable Care Act. So it was actually a business boon to them to insure 10, 20, 25 million more Americans, because those individuals would be able to avail themselves of health insurance and the use of medical devices. Think elective joint replacements, for example, who wouldn't have had the insurance coverage to do that before. So one could imagine, for example, that a target for bipartisan reform would be the taxes on health insurance premiums, medical devices, and so on. It's easy to imagine Republicans and Democrats, backed by a wide range of eager healthcare stakeholder groups, uniting to repeal some or all of those taxes, which they argue increase costs and increase insurance premiums. But then on the other side, those levies provide funding for the ACA. So this is a situation, as I mentioned earlier, where if you begin to pull one thread in the fabric, the rest of it starts to unravel. And so this is, from a political standpoint and a technical standpoint, a very, very complicated morass. And, of course, everyone in Washington seems to be fighting with each other at this point in time. So coming together around some kind of bipartisan approach is going to be extremely difficult.
But the bottom line is nothing is going to change soon, and it's not going to change fast.
It's not going to change easy. No.
And when Paul Ryan, when he said that, you know, the ACA is the law of the land, it was clear that he understood that.
Maybe for the first time.
I don't know. But things change. You know, it takes a long time. It took the Obama administration, I think, like 13 months just to come up with the bill and negotiate everything, and the Republicans tried to do the Reconciliation Act in like a month and a half. And I remember thinking to myself, oh my gosh, how are they going to even get this done in that short amount of time? And as it turned out, it didn't. But anyway.
All right. So on to just a mention of the teaching resources that instructors may find useful. And of course there's a deluge of information, of course, on the internet. But as Phil and I went through and decided to sort of hone this down into premier ones, on the ACA, I'm sure most of you are familiar with the Henry J. Kaiser Family Foundation, a rich resource on health reform information. Their daily Kaiser Health News, khn.org, gives updates from major news outlets on all the developments around, continuing developments around around reform. The Commonwealth Fund also does outstanding publications and research, and of course there are a variety of other ones. On MACRA implementation updates, we've given 3 websites here, and I would just make particular note that the last bullet for Health Affairs, their blogs are excellent, and they actually have a section when you go to their blog, one of their blogs using this address, where they talk about Obamacare versus Trump care, what's going on, and that link will take you to all the latest updates, sort of on a day-to-day basis. So wonderful, excellent resources on these sites, and many of which you'll be able to link into future ones from these as well. Okay, so future directions. As I commented to a colleague a couple of weeks ago, I was giving a presentation on this subject to University at Buffalo School of Public Health. If I knew what the future was going to hold with some certainty, I would be flying around the country with an Airbus 220 with my name on it. It's a highly unpredictable situation at this point, and particularly with what's swirling in Washington. So I think, just as a foundation, and Phil, just jump in here, as we have hopefully clarified and tried to point out that the ACA is has highly interdependent economic and program components. Pulling the thread unravels the cloth. Major changes will require tortuous deliberations. Well, we've just seen those in the last couple of weeks, with clarity of implications for population, industry, and the market. Our health insurance industry, $3 trillion plus. The number of special interests that have influence over members of Congress and over legislation is enormous. And so when the yin goes in one direction, the yang will pull in another. So there's lots and lots of tension among the stakeholders.
I would say, and apologies for my previous summary of MACRA. I know I'm just scratching the surface, drinking from a fire hose. It is extremely extensive and complicated. In fact, I was talking to the University of New Mexico here, our chief medical informatics officer. He said he's actually given up trying to keep up. He's actually hired a person full-time so that they can keep up on just the changes and the details and in the complexity of MACRA and what's coming as far as what they have to do, because they have to pull the data from the electronic health record to drive all the quality reporting requirements. It is that complex. It's that complex, and
Didn't you and I comment when they were writing the rules for MACRA, which finally, the rulemaking process for MACRA that went into effect last October, there were over 2,200 pages of rules describing how the law was going to be put into effect?
It is, I wrote a book on it, and I recognize that I only went down so many layers, and there's only so much detail. I mean, it's a full-time job just to keep up with this, you know, down to the nth degree. It is really complicated. It has many tentacles that go in many different directions, and so what I talked about is just some selected highlights from my own biased physician position. But MACRA, I think, is here to stay. Several people and agencies have written letters. Hospital associations and physician groups have written letters to HHS asking them to delay the implementation so they have more time, and they have made it very clear that they're going to implement. They're not going to delay the timeline, because I think a lot of this goes into effect next year and this year, and it is a big stretch for a lot of organizations to meet all the reporting requirements.
So as Phil said, you know, MACRA is likely here to stay. It actually passed, in comparison with the razor-thin votes on the Affordable Care Act back in 2010, MACRA passed with a vote of 98-2 in the Senate.
Right.
And in the House, it was 347 to 40 something, I think.
Right.
So it's got, I mean, it's Phil said earlier, there's something in it that everyone likes.
Yeah, if you want to start a conversation at a cocktail party of physicians, just say the acronym MIPS or MACRA, and then just listen, and then they'll talk for 2 hours. Okay.
Great, thank you. Well, thank you so much for that presentation. That was fantastic. And I think at this point we can turn things over to our question and answer session. So if you do have a question, 2 ways to do that. We encourage you to voice your question, which you can do by pressing *1 on your telephone keypad. We've got Benita, our operator, on the line who will queue you up. Or if you prefer to type your question, you can do that as well by using the chat or the Q&A box on the right-hand side of your screen. And I do see a couple of questions that have come in. Right away, I would ask, and this is a question we've been hearing a lot, and I think you've addressed that quite a bit, but just to sort of reiterate, can you speculate what will happen to the ACA?
Well, I will say again, nothing is going to change soon. And actually, if you listen to all like MSNBC and Fox News when they interview all the policy wonks, they said that, you know, what Christina said earlier, that basically they want to set aside changes in healthcare. I think they're moving on to focus on tax reform, and they're going to let this sit for a while. But, you know, it's very difficult to separate the rhetoric from the fact, and there are many people still talking about, well, we should do this, we should do that. So the bottom line is I don't think the ACA is going anywhere. It's not going to explode or implode. You know, when it was passed, they knew there was going to be periodic adjustments, just like Social Security. I think, Christina, you checked, and there was 28
amendments.
28 amendments made to Social Security, the Social Security program, over its lifetime. And, you know, the ACA is going to be the same way. And it's going to be a very slow-moving albatross. Maybe that's not a good analogy, but it's going to be very slow-moving, and it's going to take time. And
well,
I'm sure
I think the projections of potentially 24 million people in the next decade losing health insurance, and we'll be back to over 50 million people uninsured by 2026.
Right.
Things are going to happen to make sure that doesn't happen. Or, you know, we're already talking about a congressional bloodbath at the midterm elections.
Right.
Because I think the one thing that this deliberation on the Reconciliation Act did is it did help elucidate what the on-the-ground features of the Affordable Care Act are for the voters, for the American public. And so, you know, if I could just take the broad stroke and reiterate what Phil said, nothing's going to change quickly, or certainly not in the life of this edition of this book that is huge. We're going to, I think, end up building off of the principles of value versus volume care, incentivizing physicians for quality, all the things that cross over between the ACA and MACRA, but keeping in mind that this is a monstrous $3+ trillion system. We don't turn the Queen Mary at a right angle on a dime. And so this is going to take years of of deliberation and legislative activity in order to finally settle in as the way we finance healthcare. I would just remind everybody to think about the fact that in 1995, we were talking about the new traction gained by managed care. Managed care is now the way we support healthcare in this country. Managed care is the insurance mode for healthcare in this country. 25 years, 20-plus years. So things will continue to evolve. It's an extremely interesting time for anybody who's interested in the healthcare delivery system, but flip-the-switch changes are just very unlikely.
Great, thank you, Christina. And I do have one question here asking if there's a Jones & Bartlett publication authored by the two of you, and yes, there is. Just published earlier this month. This is the new 9th edition of, we've now titled it Sultz and Young's Healthcare USA. Christina Young has been a co-author on this text with Harry Sultz for many editions, and now Philip Cross has taken over as co-author along with Christina Young, but this is the brand new 9th edition, and of course, there are many updates to this edition, including the implementation of the ACA woven throughout the chapters, and lots of new coverage on this topic of MACRA and its impact on all parts of the healthcare delivery system. Lots of other updates, coverage of new trends, including mergers, acquisitions, and the vertical integration of health systems, current information on workforce issues such as the coming physician shortage, the role, certification, and training of physician assistants, trends in pharmacy and dentistry, nurse practitioners, hospitalists, and there's a new section on the increasingly important role of medical assistants. And Christina has also completely overhauled the chapter on public health, including new international comparisons and data on U.S. spending on prevention efforts with examples from the Flint, Michigan water crisis, gun violence, as well as SARS and Zika. So this is a comprehensive update, and this is the publication that Philip and Christina have written together. Turning back to questions, I want to check in with Benita and ask if there are any questions on the line.
Yes, there's a question from Susan.
Yes, my question is, does MACRA eliminate the meaningful use for all entities or just for the physicians?
Oh, MACRA does not eliminate meaningful use. It has been, meaningful use has been subsumed into MACRA. So in other words, rather than continue the meaningful use program as a separate entity, it has been brought in. And they changed the name to Advancing Care Information. But that is part of the MIPS, the Merit-Based Incentive Payment System program. 25% of the score that you get that determines whether or not you get a bonus comes from essentially what used to be meaningful use stage 3.
And so will they be moving to a stage 3 for everybody or not?
Well, my understanding is part of the problem is they've changed stage 2 several times.
Right.
So what they did is they basically took what was going to be stage 3 and revised it and then put it into the MIPS formula, okay, if that makes any sense. That's a very high-level summary. But essentially, and actually, it is based on the scoring system and whatnot. It's actually arguably some, like the American Medical Informatics Association and whatnot, has come out and said that actually the scoring, it's much harder to meet. They've kind of raised the bar with the number and kinds of requirements to meet what used to be meaningful use, which is now advancing care information, when they kind of brought it into MACRA.
Okay, thank you.
Great, thank you for the question. Here's a question on MACRA. Are providers other than physicians going to be reimbursed under MACRA? Can one more distinction be made between AMP and MIPS?
Right. So in other words, the way that I think about MIPS, and again, this is a simplification, this is what people have to do that are in the majority of the healthcare system. So for people like me that work for a university system, people that work for an HMO, people that work for a private physician group, the MIPS program, the Merit-Based Incentive Program, is what we have to comply with. In other words, there are rules. We have to select a number of metrics that we have to collect and report, and then that goes into that formula I talked about, and that's going to affect what our entity is going to collect. And The APM model, those are things like accountable care organizations, where you get a physician group and says, what we're going to do is we're going to work and we're going to identify a community. An accountable care organization defines a community. So that could be like all the patients that come to the University of New Mexico. And in that community, there's, I don't know, 200,000 patients or whatever that we're caring for. We will establish a flat rate, after negotiation with the government, that we will care for all the patients with diabetics at a flat rate per number. And whether that patient is seen once, 0 times, or 100 times a year, we're going to get reimbursed the same. And then that negotiation is carried. It's sort of like what they did in the 1970s with HMOs. It was the same kind of payment system where you would basically contract to care for a population, and they would pay you a flat rate to care for that population. And the idea is if you can increase the efficiency of your organization to drive down the costs, you get to keep the difference between what you actually pay for health care and what the government pays you. That's a simplification. So the APM is more of an organizational, it's a special kind of organization, and then the government doesn't require individual physicians to submit quality information like they do with MIPS. The organization does that as a group. And there are very few, there's going to be, the vast majority of people are going to be in the MIPS program.
Great, thank you. Here's a question. How does one address the philosophical issues regarding healthcare as a right versus no support for government entitlement programs? What should be the role of the federal government and our role as citizens?
Well, we can talk about this. I'll let Christina go.
Well, I'll just say, we have a long-standing issue in this country. For example, if we compare education, education is considered a right. Every child and individual who is considered educable at whatever level is entitled to an education to the extent that that their personal capacity allows that. We have never treated health care as a right in this country. And philosophically, we still obviously do not do that. So there is no philosophical or ethical inherent entitlement for health care in our national value system, unlike other developed countries, I might add. So I think at the level, I think about the level of political wrangling that's going on right now in the White House and in Congress, coming down to a philosophical level of whether it's a right or a privilege, is probably not going to be on our radar scope in the immediate future. I mean, I'm a career public health person, so of course I believe that the access to health care and the right to health care is quintessential, but that's not a nationally shared viewpoint.
Yeah, I would just say that that is a sort of political dialogue that the citizenry needs to have, and I'm encouraged to see that there's been a fairly significant increase in the number of citizens kind of becoming activists in the sense of calling their congressman or showing up and participating. If you look at the healthcare expenditures, we spend about 17.5% of our GDP a year on healthcare. I think the next closest country is Norway, and they're at about 12%. And if you compare our health outcomes using World Health Organization standards, we are on par with the country of Slovenia. You can search on Google search World Health Organization rankings, and it's and this is nothing new. And what it just kills. I am so personally, I just think the wealthiest country in the world, in the history of man, doesn't believe. I mean, at least currently, that healthcare is a right. Things are changing. The CHIP program, the Child Health Improvement Program, where essentially we guarantee health care now in the United States for all children at some basic level. And sort of the citizen activists that are, people are showing up and saying, well, hey, what about me? I was watching on YouTube some of the videos of some of the congressional town halls, and this one particular senator said, well, we want to implement health savings accounts. And people said, yeah, but if I get cancer tomorrow, I don't have time to save $150,000 in my health savings account. So I think, you know, things are changing.
And, you know, when we're talking about, Philip, when we're talking about lower and lower middle income individuals, someone made a comment to me, and they read it somewhere the other day, that's like a health savings account for a middle or lower middle income individual is like giving a cookbook to a homeless person.
Right.
They're unable to amass the kind of savings that would cover any kind of major medical situation. And, you know, high deductible plans, which were one of the things that were touted by certain members of Congress, are fine if you have the $5,000 upfront payment that's required in order to get your premium down. This is not the answer.
Right. The other thing I would say is that to a pretty significant extent, many people are already in a single-payer system, depending on how you count it. Medicare, all the people,
universal coverage, yeah.
Right. The VA, that is a socialized system. That's a single-payer system. People that are currently working for the Defense Department or in the military, there's a health system for them. People that work for the federal government, I think it's called TRICARE, but it's essentially a single-payer system for these extremely large populations. And depending on how you count it, between 40 or 60% of the population is being covered by one of these sort of pseudo single-payer systems. I mean, they're incredibly large. And, you know, so for the rest of the population that's covered by private insurance, with the ACA, they reduced the amount. They used to require that 70% of all the 70 cents on every dollar collected in premiums for health insurance had to be actually expended by medical insurance companies for medical care. I believe the ACA changed that to 80%.
85 and 80, yeah, 85% for large companies and 80% for small companies. Yeah.
And so, you know, so we have been slowly kind of migrating toward a single-payer system, and I think both politically and because it's more efficient. You don't have to, when the risk pools get smaller and smaller, you have to have enough reserve, so if someone in that risk pool gets an extremely costly illness, the whole insurance pool can bear that load. So when you get to small pools, it requires more and more of a sort of capital outlay to ensure that they can provide care for the sickest individual in a small pool. Well, the way you fix that is to get the largest pool possible. It's Insurance 101. You spread the risk over the largest population possible. The cost per individual decreases, and you know, this is what you know, it supports what Christina is saying. It's like a piece of fabric, and you start pulling at the string. You know, a lot of the proposals people make are to shrink the pool. It's like, why should an 18-year-old pay into insurance that covers geriatric care? Why should a 60-year-old person pay into a system that provides maternity care? Well, yeah, if you want to break it into those small pools, but when you do that, then you lose the benefit of those large risk pools. And so it's kind of
and that's a philosophical issue.
Right.
That's, you know, why should the 60-year-old pay for maternity care? Why should I be paying taxes to support a school system when I've never had children?
Right, exactly. And at least, like, in fact, there was a recent Supreme Court decision that just came down where the Supreme Court upheld that public school systems have to accommodate children with autism so that if they're demonstrated not to be performing in the public school system, the public school system has to provide an alternative, because our society has evolved to the point where we all recognize there's a public good involved with providing public education to everyone, and in fact that's evolved even for special needs children now. Right. We, for whatever reason, are compared to our colleagues, our peer nations, you know, collectively haven't had that philosophical conversation, although it's starting right now, and I think that's a good thing. So one of the good things to come out of sort of the chaos in Washington is I think the average citizenry is starting to think about this, and that's a very good thing. Yeah. We live in very interesting times.
We do. And for those of you who are wondering about the single payer, I would just remind everybody what happened with Obamacare and the public option. The insurance company spent $100 million to lobby that out of the law. So.
Wow. Well, thank you both for those answers to the questions. I think I would like to just quickly turn to Bonita just to check to see if we've got anyone waiting on the line to ask a question.
There is a question from the line of Michael.
Hi. Question is, how impacting do you think the value-based payment modifiers will be in terms of MIF payments year one in terms of their quality factors? Do you think the quality factors will change? And when is year one payments expected?
Okay, I'll try to take that one. So one, no one knows. I went to a conference last year. It was the Agency for Healthcare Research and Quality has a investigators conference. I received a grant from them to do research on sort of the health IT and physician burnout and time efficiency and things like that. And I went to their national conference, and they had some folks, some health economists that were studying this. In other words, what is the level of evidence that if the government's healthcare quality improvement organizations implement what they were proposing in MACRA, you know, what is the evidence? Has anyone done research to show that this will produce a benefit? And the answer is no. So in a sense, the level of evidence that's being used to create these programs is expert opinion. In other words, there's been no experimentation, no data collected that the incentives they're creating and the requirements that they're imposing on physicians and the healthcare system are going to do any good at all. So in a way, we're involved in a grand experiment here where, you know, and they've consulted a number of experts that study this, but if you actually look for hard data, and they had three, you know, one guy was from, MIT and Harvard, and the other one was from Northwestern, and they basically just said, you know, we really don't have any, we can't really say anything because there really isn't any evidence for or against doing this. So that was your first question. And what was your second question again?
Well, in terms of the payment, using this data, there was a payment schedule, I thought beginning somewhere in 2019.
Yes, everything's 2 years in arrears. Right. So in other words, you'll submit your data this year, they take a data and analyze it and compare it to everyone else, and then you get your penalty or incentive 2 years later.
Okay.
And that actually causes trouble because a friend of mine is in a private anesthesia group, and I was at a party and I mentioned MIPS. I said, so if you have a person now that's a partner and then leaves, they may want a piece of that incentive that shows up 2 years later after they've left your group. I said, are you putting that in your contract? And he just looked at me and groaned. So I mean, the 2-year arrears is a problem, I think, because for incentives to work, it should be very soon that you get the incentive. But, you know, a lot of people, you know, in 2 years, the turnover in primary care is huge, as an example.
Thank you.
Great. Thank you, Phil. Here's a quick question that I can answer about the book itself. The new book seems smaller. It appears to be thinner. Have the chapters been made more concise? And I can tell you exactly what the reason for that is. It's because we've gone to full color for this book, and it uses a different type of paper, which is a little bit of a thinner, glossier paper, similar to what you'd see in a magazine, you know, a high quality, but it does make for a thinner book. So for those of you who were using the 8th edition and now you're onto the 9th and you're wondering, that's why. It's not shorter in content. Moving on, we also have a great comment here, and I invite anyone who, you know, if you'd like to comment, please do, but thanks to the speakers. I would like to hear them on the news with their clear explanations of very complex topics.
Thank you.
We try. We try. We're always fearful that something's happening we're not aware of. It's really hard to keep up on.
And pardon the interruption, Ms. Teague, there's another phone question if you'd like to take it.
Yes, please. I was about to ask. Please go ahead.
All right. And this is from Rosa Lee.
My question was, what about all the insurance companies that are pulling out, refusing to participate?
Oh, in the Affordable Care Act. Yeah, there have been some insurance companies that are pulling out, but the majority, my understanding, Christina, you can correct me if I'm wrong, but the majority of the exchanges are doing very well. In fact, like in California, as an example, the first year, the costs that were coming in were lower than what the health economists were projected because a lot of the insurance companies wanted to get in on that market. This was an anticipated problem that in some states, there was a smaller number of insurance companies, because insurance companies have to be incorporated in the state that they provide insurance for. They can't incorporate insurance across state lines.
Right.
Actually, there's 3 states that you can. Maine is one of them, and I forget the other 2. But the bottom line is that this is part of the adjustments that were anticipated to be needed to be made when the bill was passed.
Yes.
And interestingly, the 3 states that allow insurance companies that are not incorporated in their state to come in and provide insurance, no insurance company has really taken that on, because it is an enormous investment to move into a new state, because you have to do the actuarial research and analysis of the competition, and
along those same lines, Phil, in response to our caller's question, there's been a huge amount of rhetoric, which our caller probably has heard, about we're going to increase competition by allowing companies to sell across state lines. That is an enormously, as Philip just pointed out, enormously complex situation, because state insurance departments and their regulations are unique to each state. Most of them have, primary provisions for things like making sure that that the insurance companies allowed to practice in their states or to sell have sufficient reserves to cover catastrophic problems and that sort of thing. It's 50 different systems, and so it's extremely complex, as Phil just indicated, to try and sell across state lines. And also, this inflammatory and reckless rhetoric about the insurance markets exploding or imploding is just not true. There's a handful of states and a number of, which contain a number of counties in which insurers have indeed pulled out. But important for you to know and to recognize that one of the features of the Affordable Care Act was that it provided premium stabilization programs, so that companies that end up with high-risk populations, extremely costly ones, would receive subsidy from premium contributed by companies that enjoy low-risk populations. So that was a provision that was built into the law, and actually, if you were to, when you leave the webinar, go to the Health Affairs Journal blog, was posted this morning about research that was done on what actually the conditions of the stabilization program are, and they're actually very good. So it's going to be critical, and I encourage people who are still on to listen and to watch during the next 6 to 8 weeks, because this is the period of time when insurance companies begin to set rates for their upcoming fiscal periods, how this is all going to turn around in terms of insurance companies staying in the marketplace or not. But for the most part and overall, this rhetoric about death spiral, that's actually an insurance term that means the risk pool is getting worse and people are dropping out. So as Philip was talking earlier, the risk pool is shrinking, so that concentrates bad risk. That actually is not happening. There is no death spiral. So this is just part of the political rhetoric that's really reckless, because it's creating an impression among the public that this thing is going to drop dead, and there's no indication at all that that's the case. Not at this point.
Well
Great.
said.
Thank you, Christina.
You're welcome.
Very well said. Thank you both so much. Bonita, do we have any questions, any more questions on the line?
There are no further questions.
Great. All right. And I think we've covered all the questions. I'm just reviewing. I know there were some questions that Christina and Philip have more than answered at this point. So I would just at this point, before we wrap things up, just point out again the new 9th edition of Stultz & Young's Healthcare USA by Christina Young and Philip Croft. If you are an instructor teaching this course and you'd like to consider this text for course use, I encourage you to go to go.jblearning.com/healthcareusa, and from there you can request an instructor's copy. You can download sample chapters. There's a full package of instructor support materials available that you can request access to. And also, this text includes access to a Navigate to Advantage package, which includes the full ebook. So your students can purchase either the ebook alone, or they can get the book plus the ebook. There's no additional cost for that. And then the Navigate to package includes other resources as well for practice activities and such. And if you'd like to make that an interactive course, you can do that as well by requesting a course ID. And then lastly, I would just remind everyone that a recording of the webinar will be made available in just a few days. That will all be posted on our new Public Health and Health Administration Faculty Lounge page on LinkedIn. Christina and Philip, thank you so much for your fantastic presentation and answers to all the questions.
My pleasure.
And thank you to everyone who joined us today. And with that, Bonita, can I ask you to go ahead and close out the line?